and hopefully we'll have a very positive meeting today. I'll open the agenda, and the first item on the agenda is the acceptance of apologies for absence. Andy, apologies?
Yes, Chair, we've got apologies from Mrs Mavis Harrison, and Councillor Nick Stansbury's indicated that she may be late because she's got a family commitment.
Okay, thank you, Andy. Item 2 is Chair's remarks, and can I also take this opportunity to welcome our 2 new members today, Councillor Clive Tennant and Councillor Martin Johnson. I'm sure you're going to find it interesting, and I'm looking forward, as the committee will be, to your contribution from 2 very excellent councillors for their area. Welcome to the meeting. As you know, members, a guide to the Skype meetings and the meeting etiquette has been circulated with the agenda. At this point, can I just also advise that in order to be as concise as we can in dealing with the matters today, and in light of the new world of technology that we're all using, I would actually suggest that we, first of all, do not type in the box. Thank you, Martin. Do not type in the box your questions or comments. Please use the system through the audio. And at the same time, can I request members, in the circumstances that we're in, that we are concise. We have the questions rather than statements around it, and it will then give the time for our guests today to actually respond, we hope, to your questions and comments. Appreciate that very much. Then that takes us on to the declaration of interest, and in the Chair's briefing I can just add as well that most of the issues you see today are contained in the Chair's briefing on pages 49 to 56 under agenda item 8. Item 3 on your agenda now is the members' declaration of interest. Any declarations of interest, pecuniary or non-pecuniary? None? Thank you. As usual in the format, as we're going through the meeting, if you feel that any issue arises that may have conflict with your good selves, just indicate, and Andy will make note of it to make sure that we are in all the governance rules. And we will apply the usual format. Item 4 is to look at any urgent items. I have none. And item 5 is to approve as a correct record the minutes of the meeting held on the 27th of February 2020, pages 1 to 4 on your agenda. I can just bring you up to 2 items on that agenda because I believe the rest may be covered in our discussions today. Minute 57 and minute 76 and minute 77. Progress in relation to public engagement and consultation on both these issues, obviously, as we know, has been hampered by the coronavirus outbreak. You can pick up the issues in the Chair's briefing on agenda page 8 there that I've given you, agenda item 8. And obviously then that will be followed on in terms of the committee's work programme, which is on agenda item 10. With that, and in mind of the progress there, and obviously those issues coming up on our work programme later on, can we move on to item 6, please? Item 6, as you know on your agenda, is to do with the public health update, and that's pages 5 to 10. At this point, can I welcome Stephen Turnbull, Consultant in Public Health, Wakefield, MDC. And the purpose of this session is to receive an update on the test and trace and outbreak management elements of the response to COVID-19. The briefing circulated with the report from Stephen provides us with an update in relation to this COVID infection position in the Wakefield district. It actually is very succinct in detail on the areas of work to prevent and manage the spread of the infection, and a briefing on outbreak management and measures to continue local outbreaks. At this point, can I welcome Stephen to the meeting? And obviously, I understand as well, Stephen, that you have a young lady called Charlotte Crocker who's asked to be a guest at our meeting to be able to get an insight as to how scrutiny works in Wakefield. Welcome, Charlotte. I hope you find the meeting interesting. And over to you now, Stephen. Go through your report, and then we'll hand over for the questions and comments. I do appreciate and realise that today you're going to have a further update to this report in terms of the issues around Wakefield, and I'm sure you're going to add that to the information that's already been sent out. So Stephen, over to you now, and obviously then we'll have the questions and the comments from the members. Thank you, Stephen.
Okay, thank you, Chair. I circulated the report, and members will have seen that. I won't talk through that in any great depth, but if I could just present my screen so you can see the latest figures. I didn't put them in the report because we see we get regular updates. I didn't want it to be out of date. I was just trying to present my screen, but I don't think it's allowing me to, unfortunately. So I may just need to talk my presentation through with members. So in terms of the current position, you'll be aware that at national level every week, local authorities' rates of infection are reviewed. They're reviewed regionally first and then nationally, and the Chief Medical Officer with his colleagues looks at the position nationally and looks whether there's any areas of the country where they have any particular concerns. And there are in effect three levels of concern. The lowest level is an area of concern, and Wakefield is currently in that list and has been for some weeks. The next level up is enhanced support, where the government offer further support for local authorities to help manage the infection and any outbreaks. And the highest level of support on the national watch list is intervention, where the government basically intervene to try and make sure that the suppression of the infection is as robust as possible. As you're aware, we are an area of concern, along with our colleagues across West Yorkshire, with the exception of Leeds, which is just off that list as far as we are aware. This list gets updated every Thursday. Decisions get made. So a decision will be made today whether Wakefield is on the list or not, and that will be publicised tomorrow. One of the reasons why we've been on the list is that our infection rates increased about a month or so ago, and that was largely because we had a number of different substantial outbreaks in the district. A couple that people will probably be aware of was one in Forza Foods in Normanton, and there was other ones in Urban House in Wakefield, and the Deep Sleep Company in the west of the district. Our current rates of infection, our published rate as of today is just over 20, nearly 21 cases for every 100,000. So in actual real numbers, rather than talking about a rate's useful when we have to compare one area with another, but just to put it into picture of what we're actually talking about in actual numbers of cases, is that equates to about 74 cases that have been tested positive in Wakefield in the last week, in the last 7 days. And if we roll back a few weeks ago, our rates were around 14 per 100,000, which equated to around 50 cases per week. So we've pretty much gone from 50 cases to 74 cases, which is an additional 50%. Now, that's 50% over 3 weeks, so we're not rising out of control, but we are drifting upwards, and that's why we are concerned, but we're not alarmed. It's not the, well, that's why we're in the area of concern, but we're not running out of control. So when we've looked at that increase, we really have to try and work to understand what's caused that increase over the last few weeks. As I said just a while ago, part of the issue we had was outbreaks. And when we have an outbreak, you will naturally get a jump in numbers. But when we've looked at our recent rise of the last few weeks, it's not really been linked to any particular outbreaks. We've had some small situations that we've been dealing with and controlling, but actually that's not the real driver here. What we've seen instead is an increase in the number of cases in younger age groups, and by younger I mean young adults, so over 20, so 20 to 40-year-olds. That's the groupings where we've seen the biggest change over the last 3 weeks. So just to put that into perspective, if we look at the cases before the 12th of August, then for the 20 to 24-year age group, they were about 7% of all the cases we've ever seen in Wakefield were in that age group. Over the last 2 weeks, that's now 14% of the cases. So our infection rate in the 20 to 24-year age group has doubled in 3 weeks. So that is where the increase is. It's in 20-year-olds and 30-year-olds to a lesser degree. And that's what we're currently now trying to understand. We understand that position. It's now trying to make sure that we try and target those age groups with clear messages that it's important that we all follow the rules, follow the guidance in order to avoid increased infections and increased risk of further lockdown. The reason why, some of the reasons why it's a difficult thing to message for that those age groups is it will not necessarily create a degree of illness. People in those younger age groups do have more often than not are fit and healthy and may have a very mild COVID experience, may have a fever, may have a cough for a few days and then get better. What we're really concerned about is we know that young people, young adults, don't just socialise and live and work with their own age group. They may have elderly relatives, they may work in a care home, they may visit people who are more vulnerable to COVID. And that's why we want to try and get the message out to those age groups to be able to control the infection in those age groups to stop us ending up in a position where we are seeing infection in more vulnerable groups. And I suspect that that's the main kind of message that we're looking at in terms of the general pattern of our infections. The other thing to note is how we are handling outbreaks. So when we talk about an outbreak, we have the definition of an outbreak is 2 or more cases that we can link either by the time that the infection occurs, or by where it happens, or is there something about the kind of people that are linked. So you could quite easily have a very big workplace where you have 2, say, cases, but we cannot see any connection between them. They may work in different departments, they may work in different shifts, they may not have any contact between them. That's not an outbreak. But if we find that there's one particular shift where there are 2 or more people who do have COVID and it came on at about the same time, then what we're seeing is then that might be an outbreak. So once we detect that, then we do encourage all workplaces to get in contact with us if they see any concerns that they've got in their workforce. And we are obviously in touch with the National Test and Trace System. If they see any patterns of infection that we need to investigate, then we call an outbreak control team. They are always chaired either by myself, my consultant colleague Claire Offer, or the Director of Public Health, Anna Hartley. We pull together a team meeting involving environmental health, our infection control specialists, Public Health England, and depending on the situation, other parties, for example, the Health and Safety Executive, and the communications team and we gather the evidence. That can involve some data about the number of cases and their patterns. We gather information by going to interview the cases, and we do also have staff who go out and visit the workplace so we can see what's happening on the ground and whether they are following COVID secure guidance. Once we've got an understanding of the picture, we try to implement control measures to make sure that we're stopping any further spread. And one thing that we've always tried to do is we try to be open and transparent with the public. If there is an outbreak, we will try and work with the business to say, we want to make this known. It's not necessarily a criticism of yourselves. We have found lots of occasions where people have been working in a very secure manner. They've been following all the guidance, but they still have some cases. And it may not be linked to what's happening in the workplace, but it might be linked to things like car sharing, for example. So people sharing cars in the way to where they work, that might be where the transmissions occurred, not in the workplace itself. So we do try and be open and transparent. We do send messages out to members and press releases to the general public, so that we're not trying to, there's no undercover element of this. We do try and be open and transparent and give the public the information on outbreaks, but also our infection rates. So we try and keep everybody informed as we can. I'll probably pause at that point. I know there's some members with questions, and I'll do my best to answer them.
Thank you, Stephen. Yes, I have two members who've indicated. First of all, Councillor Johnson Martin, you have two questions that you want to ask Stephen. Martin, can you hear me? Martin?
Yes.
Okay, you have two questions. Do you want to go ahead and ask Stephen?
Yes, please. My first question is regarding test and trace. We have 3 pubs in the club in Renthorpe. One of them is the Sam Smith's pub, and the owners told all his landlords, managers, not to take any details or contact numbers for test and trace, and that concerns me because nobody can enforce it, and that concerns me about spreading the virus. My second question is, I've been approached by a couple of people in the ward, and their neighbours came back from Spain last week, and they are not self-isolating as they should. They're in the 40s and they are totally ignoring self-isolation coming back from Spain, and that concerns me as well, because there seems to be no enforcement and nobody's bothered. Thank you, Betsy.
Stephen, would you like to respond?
Yes, certainly. So on test and trace, we are aware that different organisations are operating differently, and some are asking all members who use their facilities to, complete leave their information, leave their names and contact details, and some are certainly not. It isn't enforceable. As part of our recent rise, we have seen that change in more young adults, and so what we're trying to do is encourage establishments to use test and trace, to keep a record of names, and it can be helpful. It can be really helpful if we do have an outbreak linked to a bar or a pub. Then having that information is really helpful to us. You may be aware that we had an outbreak linked to a bar in the centre of Wakefield, the Truth Bar. Now, we do have that outbreak was largely in staff, not customers. But it would be really helpful if that situation was different and we were seeing numbers of cases in people who had been in the bar. Then it'd be helpful for us to be able to follow it through. So we are going to try and push that out and try and encourage all establishments to use test and trace, because that can really help us. The alternative is what we would do is what's called a warn and inform. So if we haven't got those details, but we do know something happened in that kind of pub, we'd probably have to write out to lots of people. We'd probably have to do lots of publicity to say, if you were in this bar at this time, get yourself tested and be very aware of any signs and symptoms of infection. which is obviously adds delay to it and makes closing down some of those outbreaks really kind of challenging. And we do know from the work that we've done that young people, but lots of people have complicated lives, and they may not have gone to just one bar, they go to several bars, they may have worked in 2 or 3 different workplaces, they may have visited people, and it really kind of can get very quickly spread from one situation to others, which is so I totally agree it's a concern, and we are going to try and push that to encourage places to use test and trace more systematically. On the second point around people coming back from holiday and not following the quarantine advice. Again, it is an issue. It is difficult to enforce. We don't have the resources to be able to follow all those cases down, but we do. We are obviously, if somebody does test positive, then we are working with the national system. In the early days, we didn't have the data available to us. We now get all the information for all the cases that test positive, so we know who they are and we can see their contact details, and we just encourage people to try and follow the guidance, follow the rules, maintain social distancing, use a face covering, wash your hands, and those are the main messages. But the chances are that people have come back, they don't feel ill at all, and they'll come here on their daily life. I think what we need to try and make sure is that people understand that it does take a few days before you may start to feel unwell, and you can be infectious before you show any symptoms, and that's a message that we probably need to push.
Betty, can I just ask a follow up on that? I mean, it's really pointless, the other pubs really in the village of Renthorpe, then actually taking numbers and names and addresses or telephone numbers, because if one pub's not doing it, it makes a mockery of it all. And I'm wondering if it's happening here, it'll be happening not just in Wakefield but all over West Yorkshire and the country. So cannot public health write to the health minister and make it enforceable that establishments have to take these details, because it's just not working?
Yeah, I can certainly take that away and look into whether we can lobby for that change. Yeah, I'll take that as an action.
Thank you, Stephen. I think a lot of people will be rather concerned at the response in terms of enforcement. It's been an issue all along the line, and the resources to do it obviously is necessary. I think the suggestion of a letter and probably something from scrutiny committee might enhance the case as well, Stephen. Can I just inform Nina, I'm sure you're watching in, Nina, there's a message here from Ruth Unwin, who is attending today with the CCG and the Mid Yorkshire, and it says, my colleagues and I are unable to get into the meeting. I can access the meeting but can't hear anything, and Andy Smith, one of the team, is unable to get in via the link.
Yeah.
Nigel and Ruth, are you able to help outside of the meeting while we continue?
Yeah, please continue, Chair. Both Andy Smith and Ruth Unwin are showing on my screen, so we'll work behind the scenes to make sure that that's recovered.
Thank you very much, Nina. Okay, right, we'll go back to the questions. Olivia, you've indicated that you've got a question.
Thank you, Chair. Very much on the lines of Martin. I mean, I have to say, I think that a lot of the things that we've been advised over the last few months have been fairly shambolic and inconsistent. But the pub nearest where we live has really adhered to everything. They've kept records, they've distanced people. You have to book a table if you want to even go for a drink. It's very, very impressive. And yet just up the road, you've got 3 or 4 deep young people at the bar or in the beer garden, and incredible social mixing and no records kept. So I do think that perhaps we need more publicity, but it's very, very confusing to see, and you know, maybe we should be giving awards to pubs that are actually adhering and not endangering their staff and their public. The other point I wanted to make, though, was that when you're referring to young people mixing, the most obvious mixing is going to be when they return to school next week. And I just wondered what advice we're going to give to children and the staff and the mixing and the corridors, particularly some schools that have very narrow corridors. I'm really concerned. And as a grandparent, I'm concerned because I pick my grandchildren up. So it's not so much the mildness of the children's illness if they get it, but it's more the adults mixing and then bringing it home. I really am concerned about it.
Okay. Yeah. Thank you, Chair. Just on the first point, I think the idea of looking at awards for places who are following best practice is an excellent one. I think we'll certainly look into that as well. So it's enforcement's one thing, but actually, recognising what good people are doing and the good practice is very worthwhile. So we'll certainly take that away as a good idea. When I talk about young people, I should really have talked about young adults. We are not seeing any change in infection rates in school-age children, and they are very low infection rates. We obviously have been involved with schools right from the start of this, right back in March. We've had plenty of schools contact us directly when they've had potential issues. We've not had an outbreak in a school setting. The transmission of COVID in amongst young children is exceptionally low. They don't seem to pick up much in the way of symptoms, and neither do they seem to transmit it readily either. It is, if I could. Obviously, we didn't want COVID. We don't want a pandemic. But if we could have one, then one that doesn't affect children is an absolute blessing. So I'm reassured that the ongoing risk of transmission when school starting is low. It's obviously beneficial to get children back into education and normality. That is a huge protective factor for their health and well-being in the long run. We are, of course, aware that there are issues in schools with narrow corridors and mixing, and that they are a challenge for schools. We have set up next week a question and answer session with public health and our infection control specialists and schools to give them direct advice. We do have a hotline that schools can contact us if there are any issues that they pick up in the school setting. And that's for all schools, and we've developed relationships with particular schools who may have more vulnerable children, like some of the special schools where we are. I'll always answer the phone straight away to one of our more vulnerable school settings. So the schools are going back. We are working with them. We'll continue to monitor that situation. It's something that we're very keen to try and support schools in coming back as safely as they can. To give children the education that they deserve.
Thank you, Stephen. Kevin, you indicated you've got a question.
Yes, Chair. First of all, I hadn't realised that it was purely voluntary for pubs to take the contact details of customers. But the question really was, are we to understand that where there was an identified outbreak at a town centre pub, are we to understand that there was no significant follow-up with customers? Because there's a great deal been made by local authorities of saying that we're the people who can do the contact and trace a lot better than these centralised government systems. But if we do have outbreaks and then customers are not followed up, one wonders what the whole purpose is of those places that do take customer details.
Okay, so if I can come back on that in terms of what happened with the truth bar, we picked up the situation. It was in staff. Transmission was in staff. So we picked that up. But then, of course, we do have to think, what's the risk to anybody who's using the bar as a customer? And there's various ways we can do that. And we have picked up one customer who tested positive. Now, we don't believe he was infected in the bar. So we do follow those details up. We think he was actually part of another workplace-related outbreak that we're currently dealing with. So I mean, it's great if we've got the test and trace data. What will happen is anybody who has tested positive will be contact traced by the national team, and if they say that they've been into to a bar and they name it, it will flag up on their system, and they will pass it to us to deal with. So there are mechanisms to make sure that we can track customers, but it will be helpful if we do have a situation where we can be proactively going out to advise people that they may have been at risk of infection, rather than waiting for them to be identified as a contact. And that's the way we do it. But I suppose the bottom line for all of this is, if we have had an outbreak in town in a bar, the staff had infection, and obviously because some of them weren't symptomatic, they didn't have symptoms, so they were working while they were probably infectious, and we haven't picked up any cases in customers, which does show that this can work if bars follow the guidance. And that bar was very COVID secure in the way it was operating from front of house. So again, you had to book tables, you had to be distanced, and there was lots of cleaning in place. So it does show it can work. So I want people to use test and trace and collect details, but the bottom line is I want them to be operating socially distanced and following the guidance as to their best degree, and that way we'll stop outbreaks. Even if there is a case in a bar, you shouldn't be identified as a contact if things are run properly.
Okay, thank you, Stephen. Next on the list is Councillor Cruz. Gillian, you have a question?
Hi, thank you, Chair. Yes, an area of concern that I've noticed is particularly for me where I live, both local shops just up the road from me are not insisting that customers wear face coverings. They are leaving it up to customers themselves to wear them, and most aren't. Now, obviously, I don't want them to lose trade or anything like that, but is there any way we can put pressure on small business owners to insist that customers do wear them? I think, if you can go into a shop and not wear a face covering, it's very easy to go into a pub and not be careful too. And I think, it's linked, and we should be pretty consistent in everything. I just wondered if any ideas on where we move forward with that. Thank you, Chair.
Yeah, that's a really important point as well. Face coverings are advised, and we want people to use them in any indoor situation where they can. Obviously, some people are exempt from wearing face coverings. If you've got a respiratory problem, or if if wearing a face covering creates some anxiety with you, then there's no insistence on that. But that doesn't mean to say that shops can make exceptions, because people can be exceptions themselves. But we have heard of some shops having posters outside saying you don't have to wear a face covering. That local intelligence is really important, and I'd be more than happy if you contact me out of the meeting and share the details. We can look at trying to get a visit and some contacts to those establishments, just to gently persuade them that insisting on face coverings, unless people are exempt, is the right way to go, and will protect. It will protect them as businesses, but it will also protect their customers as well.
Thank you, Stephen. I'll do that. They do seem to have a pretty blasé attitude towards it. It's quite worrying. So yeah, thank you for that.
And that's a general thing for all members, really. Please do get in touch with us if you've got local intelligence on the ground. We can try and follow things up, and it helps us to see a pattern as well. So, don't worry about inundating us with emails and contacts. We'll cope with it.
Okay, thank you, Stephen. Councillor Fishwick Simon. Can you hear me, Simon?
Can you hear me now?
Are you there? Okay, you have a question for Stephen.
Good afternoon, Stephen, and it's just on the face coverings. I'm quite confused about this face covering situation. I've got people, I run obviously a shop myself, but I've got people now using socks, underwear garments, they're using shirt sleeves, they're using scarves. Now we're talking about something of a virus with the figures of what what's happening. I'm completely not getting this with this face covering completely. If we've got somebody as a tradesman going in, obviously using asbestos, they'll be using a certified face covering, or if they're using obviously a paint spray, there'll be a certified face covering. What we're seeing is more of a fashion accessory. If this situation is as bad as what we're taking out here, why are we not having some kind of biohazard boxes dispersed to everybody's house, so these masks can be medically certified and can be disposed of on a daily use? What I'm seeing in Horbury and surrounding villages is face coverings and masks been discarded down the streets all over, and I'm quite confused. The virus is as bad as what people are making out and saying. Why have we not got something coming down from government or coming down from council or whichever to say that these which have to be disposed of into a biohazardous box, collected by the council and actually incinerated? I'm seeing football teams, Leeds United, Castleford Tigers. It's become a bit of a fashion accessory now, and I'm a bit not with it at the moment, I don't think.
Okay, yeah, I can try and answer that. I suppose that there's, and it is complex, and there's a difference in terminology between face masks and face coverings. Yeah, so if I just try and talk you through the purpose of, and there's different, so try and talk you through the different types of face coverings and face masks and what the purpose of each of them is. So right at the top end, so you've got what's called an FFP3, which you may hear about. And those masks they need to be fitted to a person's face, and you can't just put them on. And they are the most secure face masks you can get against all kinds of viruses and particles. And they will exclude a lot of, virtually all, or nothing really gets through them. You may have seen pictures of some NHS staff with bruisings on their faces when they've done long shifts. That's the kind of mask that's there for.
I've seen them on the internet. I'm actually Googling them all.
Yeah, you'll see them there. So that's the FFP3, and we only use that where there's a risk of what's called an aerosol. So the virus is obviously minute. It's invisible. It can get through pretty much anything, but it can only really transmit when it's attached to a droplet, and the smallest kind of droplet is an aerosol spray. And there are some medical procedures that will produce an aerosol. So if you imagine going to the dentist and they're swirling around in your mouth and they're using the suction, that can create an aerosol, which means that's why dentists stopped for a long time, because that aerosol mist can get through a lot of masks, which is why you have to use that top end FFP3. There's another type of mask, which is the general kind of medical mask, called a type 2R mask.
Type 2R, yeah, got it.
Yeah, and you'll see that lots of people are buying those and using those out and about. And those are your general kind of medical surgical masks. They will protect against, aerosols would go through them, but most normal droplets, they will stop most normal droplet spread. And that's useful for the vast majority of kind of health and care settings, is that we use those kind of masks. And then you've really got face coverings, and the point of a face covering is it's a different thing. The idea of a face covering is it won't cut out those smaller particles, those smaller droplets, but it will cut out the big ones. And the switch here is the face covering doesn't protect the person who's wearing it as much as protect the person who's near them. So if you've got the virus and you're wearing a face covering, and that's just a fabric one, and you can make them out of various materials, it is better if they're at least double layered. A single kind of like sock covering is probably not helpful. So, and there is guidance on the the government website about what kind of standards you need to be looking at. But that kind of double layer fabric cloth thing, if you imagine that you kind of like breathing out, you've got lots of little droplets, or you're talking, you'll have lots of droplets. If they've got COVID on them, that face mask, that face covering will stop them. So if you've got COVID and you don't know about it yet, and you're talking face to face with somebody, then that will probably stop them becoming infected. So it's not about protecting the person wearing it, it's about protecting other people. So my mask protects you, your mask protects me. And that's the real difference. It's only there to stop those larger droplets that we produce when we're normally talking or breathing. It's not those kind of like medical procedural masks. And I suppose the other point of your question was about waste. I mean, there's two parts about waste. It annoys me greatly to see littering and rubbish anywhere, but to see face coverings and face masks littering it's a byproduct of the age we live in, and it's really unfortunate. And we obviously don't like to see that. But the other part about it is, if you're somebody who's got COVID and has breathing into their face mask, and as long as they follow the guidance, they can wash it in a washing machine. That will get rid of the virus. The virus is coated in what's called lipid, which is basically a fat, and normal soap destroys that very, very easily, which is why hand washing with soap is a really good defence, because it not only washes it off your hands, it actually destroys the virus coating, and then it can't survive. Which is why soap is actually better than sanitizer. So there's not a great biohazard about having face masks around. But if you do have cloth face coverings, then washing them will resolve any issue with COVID on those. Sorry, that took a while.
Thank you.
Thank you. It is a case of the messages that are going out, and as we've said previously, too many mixed messages, but the one message that's being clear to everybody is the value of wearing a mask to protect yourself and to protect other people around you. Now, I have Andy. I know, Andy, you're wanting to add some value to this debate. Would you like to come in? Can you hear me, Andy? No? Okay, well, we'll move on. I know that Kevin and Martin wanted to come back, but I'll just go to other people if I may first. Linda Gatecliffe. Hello, Linda. You've got a question? Linda, can you hear me? Looks like...
There we go. I've unmuted it now. Yeah, can I just come back to school children, please, because they're obviously going to be back in the classroom very quickly. And yesterday I heard a government spokesman saying that if there was an outbreak in a school, that other children would not be tested unless they were symptomatic. And as you've just described, many children will be asymptomatic when they have disease. So I was wondering how we're going to protect the teachers and other adults with whom these young children come into contact if we're doing very limited testing. And is that going to be the case in Wakefield?
It's a good question. I'm not aware of that statement, so I can go and double check that, and obviously feedback my findings. I can do that as a matter of urgency, given schools are coming back shortly. What I would say though is, in terms of if we do get a case in a school, there are procedures in place. So if somebody becomes symptomatic in school, then there is a procedure for what to do and how to protect the child and protect any further transmission. And as part of that, we would then look at trying to understand whether any teachers or other staff would be defined as a contact, and whether they would be at risk of infection from that child. If they were, then we'd ask them to isolate and not come into work, and we would probably then look at their clusters of children. Obviously lots of schools are trying to work in a less mixing way, so we'll be able to understand whether they are in any classroom bubbles, and we'll probably look at each case on its individual basis and make some recommendations as to whether the whole bubble needs to isolate, or we'll just or we'll take a different approach. I am aware that schools are going to get a pack of test kits as well, so if a child does become symptomatic in the school, they can have a test there and then. And it also helps to test children if for some reason they think that maybe parents wouldn't take them for testing, then schools can look at trying to use those packs to support those kind of situations. But I will come back on the detail on that.
Is it true that schools are only going to get 10 test kits per school?
Yes, that's the latest guidance. Yeah. But obviously, what we have got in Wakefield is we've got to try to a local offer, and we're trying to support some additional capacity for testing for all of our communities, including children.
Okay, thank you very much.
Thank you, Linda. Thank you, Stephen. Before I bring Martin and Kevin in, is there any other members who want to ask a question of Stephen? Any other members that haven't asked a question yet? Okay, right. Martin, you want to come back quickly with a question, please? Martin, can you hear me?
You said earlier there was a dedicated phone line for schools. Is it possible to have a dedicated confidential phone line for the public? Because, you know, people that have come from abroad, that the government said you shouldn't really have gone there, and coming back and not self-isolating, people uncomfortable, neighbours, you know, reporting them because they think it could cause major issues. And obviously I've been told about the one I raised earlier, one of them actually works in a school, and they've been to Spain, they've come back and they're not self-isolating, and people are frightened to report them because they don't want to fall out with them. So can we not have a confidential phone line where people can report or make you aware that they maybe need somebody to go knock on the door?
Yeah, and I think the possibly so obviously if we set up a phone line, we need to think about, you know, staffing and hours of operation. But I think probably the best thing would be to go through the council's customer service number, and then they can pass it on to us. And we have had cases where issues have been raised through the council's phone lines, and they do reach our inboxes, and we will try and respond to them. So maybe that's the best advice. So and again, if you've got any concerns as members, then by all means do get in touch directly, and we'll try and pick those up.
Thank you, Stephen. That's a good idea about the customer care centre. And Kevin, you want another quick question, please?
Yes. My experience of trying to get in touch directly was extremely frustrating. I had an issue to report. I wanted to speak about it. It's time's gone now. Given the names of two appropriate people by an appropriate, very senior person, absolute nil results in both cases. No phones answered, extremely unsatisfactory answer phone messages, and neither of the parties ever got back to me. I think, like Martin, we do need clear, transparent, effective, workable arrangements so that things can be reported and hopefully acted on. Thanks, Chair.
Thank you, Kevin. One or two issues that I'll just bring up from the members, and for this not to be reiterating too much, of course, the government placed the responsibility on local authorities in the relation to test and trace, as we all know. The members today, Stephen, have brought up the issues, and I think a lot of people out there who may be looking into our meeting this afternoon will be surprised to hear that enforcement is a huge issue, and the powers really haven't been given to local authorities to do as you suggest. I know from Friday there's going to be a change in some of the enforcement issues. As well as that, in terms of the members' views, it's also important to say that from the local authorities' point of view, knowing the local people and the local area, which is vital, you can only do the important issues of test and trace given that you need the resources in terms of people to go out and do it as well. So that's something that I think is lacking in terms of the resources that you need. I'm just going to come on to the report, if I may, to bring some issues back with you, Stephen. And I'm conscious of time because our colleagues are coming in soon from the Mid-Yorkshire. I don't want to curtail it, but we have the agenda to go through. When I look at the report, Stephen, and I'm coming back on some issues that you said, in the report on page 9, under testing, it says, your report, we are progressing with further plans to expand our testing options. It would be very useful, Stephen, if the progress on those plans could be made available to the scrutiny officer and myself, and we can actually then make them available to the members of the committee. And secondly, in terms of visiting premises, I understand that the police and enforcement from the authority have been visiting premises around Wakefield, Castleford, Pontefract, etc., to find out about the issues about social distancing, and in some cases they have been given some warnings. I'm sure that you are aware of the method that they use, and you're probably part of the team as well. And there's one last issue, if I may, Stephen. You mentioned, obviously, the most important part of the information today, as well as your report, which is excellent, is the sad news that the numbers are going up in Wakefield. And you did say that as an area of concern, that the meeting that you had with the COVID team, which was publicised in the newspapers and apparently on calendar, you did say that you're awaiting information of the list tomorrow. I just need to expand on that, if I may, Stephen, because tomorrow is when the new enforcement rules from the government comes into play. And as well as that, if, and we hope it isn't the case, sincerely, that the situation in Wakefield changes, we are now coming into a bank holiday weekend. What would be the position in terms of the changing situation to notify the public of any changes that may be necessary? And I'll repeat, we certainly hope it's not the case, but do you have a plan in place if on that list tomorrow the situation changes?
Okay, thank you. I'll just touch on a couple and finish with that last one, if I may. So testing, yeah, I'll certainly talk to Andy about giving an update on the local testing arrangements that we're currently working up in some of the areas that we are concerned around. Issues around powers. It is absolutely right, Chair, that at the start of the pandemic we didn't have powers to be able to take actions. We do now. We can prevent specific events from happening. If we think there's a risk to health, we can close premises down. Obviously we don't want to do any of these, but and what we always try and do is work with people to agree together that if a place needs to close, then a place needs to close. But if they refuse, then we do now have local powers to enable that to happen. And on terms of the timing of the watch list announcement, you know, our rates have increased, but they have not, as I said at the start of the conversation, our rates have gone up, but they have not. They are concerning but not alarming. We are obviously aware of different options that could happen if we were to have more restrictions placed upon us. Even in areas where those restrictions have applied, like in Calderdale and in Kirklees and in Bradford, those have been around restricting people from visiting other households rather than closing down business sectors. So we don't anticipate any local lockdowns this week in terms of you know, changes to opening for bars and clubs or open spaces. But obviously we, in all of our planning for when we reopen from lockdown, we've always been mindful that can go the opposite way as well. So plans are in place if we do need to take action to restrict access and move back to a local lockdown. We have rehearsed those plans. We are talking and doing some publicity with council and colleagues, particularly around police, around the bank holiday. We want to see people out and about. We want to see normality as far as we can, but it is, at the end of the day, doing that in as safe a way as possible, being COVID secure, maintaining that social distancing, using a face mask as we've rehearsed, and certainly leaving your names and details would be obviously helpful. So we're hopeful that we won't have any negative change in our status, that we won't be going up into higher levels of intervention. We have been proactive. We have tried to take action early to try and put a lid on these increases. We had a visit from the national team. They were very happy with our approach and our comprehensive kind of ways to try and suppress any infection growth. So we're hopeful that we won't be seeing any immediate change, but it's obviously incumbent on all of us to try and maintain that and keep the infection rate no higher than it currently is.
Thank you, Kevin. Now, in terms of the age group of the increase that you've mentioned across the district, is the social network, the Facebook and the Twitter and all the rest of it, is that used in a way that you can get messages out to the generation that use their phones for connecting with their friends, as a reminder of the do's and the don'ts in protecting themselves and protecting others, as you mentioned? Is that used at the moment, Stephen? And if not, is it possible that something could be put out there that would connect with the mobile phone users as a constant reminder?
Yes, absolutely. We do try and use social media and Facebook and so forth. Obviously, you've got to understand that younger age group don't necessarily associate the council as a place to come for sources of advice necessarily and information. We have done some research. We commissioned a company to do some research to interview and run focus groups with Wakefield residents, including in these target age groups, to understand where they get their information from and what messages have stuck and what messages might have been missed. We are trying to respond to that, and we are trying to develop some better ways of communicating with those target groups through mobile phones, through different bits of social media that I have absolutely no understanding of at all at my age. Things like TikTok. I'm hopeful nobody will ask me a question about what that is, but that's one of the new social media platforms. We're trying to engage with that, just to try and use different avenues to make sure that we reach all of our communities.
Thank you, Stephen. And I've just one last comment, if I may, on page 10. You've actually put a paragraph there about the winter and flu situation and the increased risk associated with those pressures on the health system. Are you staying around, Stephen, for our next report from the Mid-Yorkshire and CCG? Because obviously that's part of their report as well. But I'll understand if you've got to go and do other things, we can catch up later.
No, I'm happy to stay, Chair.
That's fine. Okay, thank you, Stephen. Right, I think, well, it's been very useful having you here today, and I hope that the comments about the masks and wearing masks to protect, and indeed the comments that have been made about premises who should be having users wear the masks, except those that have exemptions, and trying to keep people safe as well. And I hope that's the message today following your presentation. We will keep in touch, Stephen, because obviously it's a moving situation, and we will look at the situation as we go along and connect again as necessary, Stephen. Thank you for your time today, and I'm pleased that you're going to be able to stay with us for the next presentation on item 7. So with that, members, can we move on to item 7 on the agenda, hoping that our colleagues from the CCG and the Mid-Yorkshire have been able to link up to our system. Nina, can you advise us if they've been able to link up, please? Hello? Nina? Ruth is connected via phone. How about the rest of the team, Nigel?
Unsure. It's only Ruth I've been in contact with.
Okay.
I don't know if they're all in a conference room or anything listening to it.
Okay. I've got a message here from Dr. Greg Connor. He says he's linked in now. Greg is linked in. So we had 2 more people trying to link. Oh, we've got Andrew Smith. Andrew's linked in. So we've just 1 more that should be linking into the conversation. We've got Dr. Greg Connor. We've got Ruth by phone. We've got Andrew Smith from the Mid-Yorkshire, and we're just awaiting Joe Halliwell, who's the Director for Reset and Stabilisation. So perhaps then what we ought to do is move on to item 7, and hopefully Joe Halliwell will be able to connect. If not, I'm sure Ruth or one of her colleagues will be informative to us. We'll go ahead with that. Andy, are you able to connect?
Yes, Chair. Unfortunately, been unable to get in once or twice over some of the debate, but obviously I'm back in at the moment. I just had a message from Andrew saying that Joe's actually now sending an apology, so I think other than Skelton, we're all here.
Okay, right, thank you. I thought there was something that was stopping you getting in, love. But there you go. And before we move on to this particular item, the recommendation on the item that you've just heard in terms of the public health is that the committee, we've received the report and we assess the level of assurance members have on the robustness of our local response to COVID-19. I think from what we've heard today that we can conclude, members, that our local team here have a robust situation in place, trying to deal with very fluid circumstances, and obviously more resources would be useful to the team and the authority coping with the situation that we're in. We'll wait to see what the list says tomorrow, but Stephen seemed to be confident, but there again, things change, that from tomorrow it may not be as dark as could be anticipated. So we will have the public health send us those plans that I indicated, and as soon as we get them, we'll share them with the members of the committee. So that's the recommendation on item 6. Do you agree? If anybody doesn't agree, just let me know, please. If there's silence, you all agree. Thank you, members. Thank you. Right, we'll move on to item 7, which is the COVID-19 Health and Wellbeing System, pages 11 to 48. And as already mentioned, we have representatives from the National Health Service, Wakefield CCG, Primary Care and Mid-Yorkshire. And it's Dr. Greg Connor, Chris Skelton, we've got Ruth Unwin, and obviously we've got Andy Smith. Andy is the A&E consultant in emergency planning for the Mid-Yorkshire. Joe, as you've heard, can't meet us today for circumstances, but I'm sure our other colleagues attending today will give us any information that the committee requires. And it's covering the background in terms of some of the issues that have been mentioned in the public health report, the symptoms, patient profile, systems response, including general practice, care homes and community service, and indeed the system recovery, including urgent actions and service imperatives. We consider with them in the presentation the the details of the incident plan. And the concluding part then will look at the lessons learned and the new ways of working and planning for the future. In your papers today, you've had a lengthy presentation on several items that have actually filled many, many pages. And what I did suggest, and has been sent out by Andy, and I hope you've all received it and had time to actually look at it, was a more detailed, shorter brief that would enable you to look at the brief outside of these papers, give you a more acceptable overview, and then be able to ask questions and comments to our colleagues today. And I hope that that's going to be a way forward. So with that, Ruth, are you in by phone? Greg, are you there? Dr. Connor?
I am, Chair, yes.
Okay.
Would you like me to start off?
Yes, please, Greg. Thank you.
I hope you can hear me okay. Thanks for asking me to come, colleagues. The areas that I want to touch on briefly are those on agenda page 19, and then just a little bit further on to do with flu immunisation. I know that you've got a very heavy agenda, so I'll just make a few comments and then it will give plenty of time for questions for people. From a general practice perspective, there have been three priorities really through the COVID-19 pandemic. The first was keeping patients safe as possible, especially the vulnerable patients. Secondly, keeping urgent services open, and thirdly, working with hospital and community services to try and provide a joined up response. At the beginning of the pandemic, the focus really was on making sure that practices were buddied up, and if something happened to a practice, there was another practice that could support them. We established 7 COVID-19 assessment centres based in general practice to see patients with symptoms, in the hope that that would keep some patients within primary care and mean that they didn't have to go to the emergency department, as it was unclear if we would be overwhelmed at that point. And Mid York set up a COVID-19 visiting service, home visiting service, which councillors may have had feedback from the residents, but went down very well, and also served our care homes. The second phase really was continuing what's called total triage. So what members will have noticed is that almost at the start of the pandemic lockdown, NHS England gave instruction to practice to move to something called total triage, which is to say that before patients were booked in for face-to-face assessments, that they would have a telephone or video or occasionally online consultation first with a doctor or a nurse. So in the second phase, if you like, we've continued with total triage, but reintroduced some public health measures. So making sure that immunisations, particularly childhood immunisations, and smear screening continued or restarted, some health checks and some monitoring checks of patients. And also at the beginning of the pandemic, people with symptoms were directed to NHS 111. These calls are now being transferred back to general practice from NHS 111. There was also in phase 2 a more structured support for care homes when it was becoming apparent what trouble they'd had. And our primary care networks are now aligned to all our care homes. Most of our practice were before COVID, but that's been a spur to do that more. And the final phase really is trying to maintain same-day urgent access through the telephone, video and online, doing more face-to-face work, resuming all routine services as soon as it's safe to do so. So they're slowly coming back on stream, particularly things that can't be done over the phone, like face-to-face diabetic checks and some other chronic disease checks as well. And on the back of COVID-19, trying to develop a new access model for general practice in Wakefield, because some of the things that have been done have been beneficial for patients, and some, like telephone and video, other things that have been problems. For example, patients with hearing impairment, obviously they can't use a telephone triage service effectively. So there's quite a lot of learning to come out of that. and we've done a big survey which is still open at the moment with 3,800 replies so far, which I think Access is coming back to OSC in December. And if colleagues, elected members, have got feedback from either your own experiences or from your local residents, that would be really helpful for that survey, because that's going to inform the forms of GP access in Wakefield after this. There's development of the primary care networks. They're hiring pharmacists, physio practitioners and social prescribers to support their work. And a big area of work for general practice and all the other services at the moment is gearing up for the flu immunisation programme. As colleagues will be aware, that's been expanded now, so the age cohort will include people above 50 instead of just people above 65, but will also include all the people with chronic diseases or other vulnerabilities, and a great effort's being made to make sure that we get our uptake levels up so that we're including people who are particularly at risk, which COVID has exposed, I think, particularly black and minority ethnic groups, people with learning disabilities, and obviously some of the existing ones such as care home residents. The final thing I would say is that a big new area of work too is even closer work with hospital specialists, and without treading on toes of Andrew, who's the Associate Medical Director at Mid Yorks, there's a big push on trying to bring our urgent care system a little closer together, as we've discovered the benefits of trying to work together through COVID. And the planned care thing, there's been a lot in the press about patients having to wait longer for outpatients and risks to cancer treatment and so on. So together, practices and hospital consultants are prioritising patients, trying to make sure that cancer patients and urgent patients get priority, and to manage other patients as best we can with the restrictions we've got in terms of access to tests and treatments at the moment. So that's a whistle-stop tour, Chair, and obviously I'll be ready for any questions later that members have.
Thank you, Greg. At this point, I think it would be useful if we can bring Andrew Smith in. Hello, Andrew. Welcome to Scrutiny Committee. And you're going to deal with your aspect and also able to cover the reset aspects of on behalf of the Mid Yorks, the Deputy Chair of the Reset Steering Group. So you want to follow on from Greg, please, Andrew, and then we'll take the appropriate questions to you both.
Thank you, Chair. Can I just check you can hear me? Is that okay?
Yes, can everybody hear Andrew? Yes? Okay.
Well, thank you, Chair, and thank you for the committee for the invite. I'm very pleased to be here. So, as you said, I'm Associate Medical Director and the clinical lead for EPRR. EPRR stands for Emergency Planning, Resilience and Response. So, was the tactical commander for the COVID outbreak, and now have continued working as the Deputy Chair for Reset. So, as a number of you will have seen from the slide deck we sent out for you for your perusal, we had a clear command and control structure put in place following our COVID-19 incident plan. And very interesting on that, look, we've all had flu plans, but COVID is very different to flu in the sense of its prevalence, but also the testing available. We can do a point of contact flu plan, which we'll probably talk about later, but we can't do that for COVID. So a clear command and control structure with clear communication was put in place, and I'm pleased to reiterate the point that Greg makes, is that we have worked collaboratively as a team across the Wakefield CCG, and for us at Mid Yorks also the North Kirkleigh CCG as our health partners, and through that I think we've delivered a very pragmatic and caring response to the public. We had to change very many ways of working, and setting up red and green pathways and making sure that our emergency departments could segregate on patients on arrival and with our wards. And again, that was done collaboratively with our GP colleagues to make sure that we could provide the care and ensuring that our decision making was always patient and staff centred. So in the Wakefield CCG, Mid Yorks cared for 571 patients at the time of this presentation. We've had a slight increase over the last few days with the increased prevalence that's been discussed. I led the report on the lessons learned, and there's quite a few lessons learned, which is always the key from any incident. I think the biggest thing is to stress to people, this is not like our normal major incidents, which are a sprint. This is a very clear, long marathon, which will continue into 2021. So I've pulled out a few of the lessons learned. Clearly in the time frame we've got, it would be appropriate for me to go for them all. So we did learn how to work more distantly with non-face-to-face where appropriate, and we continue to continue that with our reset agenda. Clearly, some patients need a face-to-face consultation, and therefore we are working through those pathways, and again, as Greg kindly alluded to, working closely with our GP colleagues to deliver the best pathway we can for our patients. We had to set up specialist teams, so preparing the PPE. There's a lot's been around the PPE and the challenges with the supply chain. And currently I've just taken over chair of the PPE group to ensure we have the resilience if we move into a second peak and the challenges of winter. We had a support team going around and supporting the staff to understand about donning and doffing of PPE. We had to submit on at the mid of the COVID outbreak, we were submitting 16 reports of data a day to enable the understanding of where we were and where we were progressing. So a whole team was put in place for that. Fit testing teams to make sure that FFP3 masks were appropriately used. A number of trusts in our region didn't initially use fit testing, but it is actually a health and safety executive requirement. And one of the facilities that we were able to set up was the end-of-life facility, which enabled visitors to be able to attend and be with their nearest and dearest at difficult times, and we were able to supply the PPE, etc. for that process. So, as I've said, a protracted incident, so we need to make sure that we've got the reassurance in place, the resilience, that we can manage a further extension of our current prevalence, which obviously we're very closely watching the figures as you are for tomorrow for when we'll be informed further. What is key is in moving forward, that the reason why it's called reset and not restart is that we can't go back to the way we were. Simply because that we now have to have social distancing, we have to have people wearing PPE, which takes time to don and doff, we have to clean areas, and particularly if you're using aerosol generating procedures, which require the higher level of PPE that was mentioned by my public health colleague, then we have to make sure the air settles and the area is cleaned. So it's impossible to try and do everything we were doing the way we were doing previously. So therefore, we want to take the lessons learned to make sure that we can deliver the care required for our patients and the community. And if we can, we'll use non-face-to-face, but where we need to have face-to-face, we have to do that. But that's very differently. We can't have waiting rooms full of patients anymore. We have to make sure that their arrival is timely, they are seen timely, and where possible, reduce the footfall on the hospital estate by trying to develop one-shop stops where we can have patients having all those aspects done at once, which is more efficient and more effective, hopefully. We have developed new pathways. Cardiology in particularly have had a brand new pathway, which is again worked with our CCG colleagues to put in place, and excellent feedback we're receiving on questioning people around that. So we have set ourselves quite a few targets for the end of the year, and in particularly we want to make sure that our elective activity at least levels required and the phase 3 letter. I'm sure you're all aware of the phase 3 letter that was shared to all healthcare providers, that we need to be backed by the end of September to around 80%, 90% by October, and ideally 100%. Now that letter has been followed with further communication from the state, and ideally we need to try and catch up, so that requires over 100%. You will obviously just heard I've just said there are restrictions to how we worked previously, so we do need to be initiative and work with our GP colleagues through the CCG to make sure that we are providing the best we can, the highest numbers, the most efficiency that we can with the estate that we have, and we are working very hard to ensure that. In that, we are undertaking a gap analysis of where people were providing their service to the same time last year. And you can imagine with those confounding factors I've just described, that is a challenge. But our job in Reset is to work with the teams and to find the solutions so that we can try and get at least to the 100 where we are. Bearing in mind, at the same time as the Phase 3 letter was the NHS People's Plan, asking us to continue to care for our staff and ensure not generating burnout. A lot of our staff during the April, May, June were redeployed to enable us to provide the facilities for surge in the high demand patients on the acute respiratory unit or intensive care. Most of those staff have now gone back to their previous jobs, and they're now having to switch back on the full services that were in place prior to COVID-19. And we are concerned that our staff are tired and we need to look after them, and therefore we've got to continue to work with them collaboratively to ensure resilience. Some of our pathway measures I've already mentioned is reduce the number of steps in the pathway and reduce the overall time on the estate. And all of this is to maximise our use of resources that are available to us. So current focus strategically is to strengthen our strong relationships with our clinical mission groups, our primary care network, our Cancer Alliance, our clinical leads across the healthcare economy and other private providers to maximise opportunities. And you will be aware that the independent sector contract has been extended, and we are continuing to increase our number of operating lists. And we're now up to, by the end of this month, we'll be running 21 theatres, which is a large increase. We will need to continue strengthening and update our transformational governance and the opportunities of capital investment. So we all continue to work collaboratively, and what we have seen is that we are back up to fairly several areas today are reporting that we're at nearly at 80% of return of our activity, which is really pleasing to be able to report with the support measures that we've put in place. And we will continue to do that. And the latest report was outpatient appointments at 72% pre-COVID levels, and follow-up outpatient appointments at 92%, and say our theatre capacities around 70% and increasing, with in some days putting 3 sessions on, with staff providing extra sessions into the evening. Our emergency departments are nearly back up to the attendance prior to COVID, which is a slight concern with the restrictions we have in our social distancing, and we continue to work with our CCG colleagues to understand why the numbers are back to where they are and identify how we can help the public access the right port of care and attend the emergency department when it's really needed, so we can provide that emergency care when it's really needed. Our adult community services have continued to see patients in the community throughout the whole of the pandemic, and we continue to make sure that we provide that, and we've got a 24/7 single point of contact for all patients, including the end-of-life provision as mentioned earlier. I'm going to conclude now, being cognizant of the time, but I would ask that the members of this meeting do take the opportunity to look at what is on page 48, the last slide of the mid-year presentation, where there is some testimonies of the patients that were successfully treated and discharged, and particularly the clip from Sally Ann, who produced a very good auditory of her response and was very praising of the care that was provided under very challenging circumstances. Thank you, Chair.
Okay, thank you, Andrew. Before I open it up for questions, I think it's important at this point that on behalf of the committee that we actually give our thanks to all those frontline staff in the hospitals, in the care homes, our local authority partners, our staff in the local authority, who through the partnership of supporting people in need provided sterling jobs on behalf of the community across Wakefield district. And I'm sure all the members will endorse that praise and thanks to all those and their families. We mustn't forget the families, because you know, they were part of the process of supporting their loved ones when they came. And although didn't come home, and their families, how they had to cope in these tragic situations and tragic times. First question I have is Councillor Clive Tennant. Clive.
Thank you, Chair. I think the phrase comes to mind, not all heroes wear capes.
Yeah.
My question is on the home visiting service, Chair. Some people who are infirm have difficulties getting to surgery. Could the home visiting service provide flu immunisation at home?
Andrew or Greg, who want to respond to that?
I think, if I may, Chair, I think certainly if there are people who are not going to be able to get, or for whom it's not safe to come to surgery, then there are two options which are being explored. The first would be home visits for flu immunisation, and that would certainly be offered by the community services if the patient's on an existing caseload or can be added to a caseload. The second is that for patients who are able to get in a car, there will also be we're working on a system for sort of drive-through immunisation, if you like, so a person doesn't have to get out, struggle into the waiting room, go into a room to be immunised and so on. So we are trying to look at options for people who have significant mobility problems.
Okay, thank you, Greg. Any other question? Any members? If not, while you're about and reading your report, I have one or two, if I may, and Andrew or Greg, as appropriate, you can answer. On page 41 of the presentation that you sent out, it says on the last 3 bullet points, review of services as yet not fully operational. Can you tell us what those are? And this is for the current focus on operational issues. New routine referral pathways, and then there's direct access pathways. Could you just expand on those 3 bullet points for us, please?
I'm happy to talk a little bit. Andrew may know a bit more detail than I. What we're trying to do is to make sure that, if I can put it into context, at the beginning of the pandemic lockdown, we took the decision that all urgent and cancer referrals should continue to be made from general practice into the trust. But we decided to hold on to non-urgent referrals to allow prioritisation of the patients with more urgent problems, and also time to set up new systems for more efficiently managing patient problems and giving them access to restricted diagnostic tests, and that's something that was alluded to. Now all the services are coming back on stream for non-urgent referrals, and within the next month they will all be open for this. Practices have gone through the list of patients who are waiting to be referred, and to make sure there aren't any urgent patients in the list, and also to see if some patients still need a service or in fact have been sorted out in primary care with consultant advice, and that accounts for a significant proportion. The rest will go through the new access point for each specialty, and the difference will be, rather than patients being referred to into a long waiting list, those patients will be assessed by consultant colleagues when the referral is received by the trust, and therefore a plan can be made for each patient, rather than the patient just getting a communication to say, yes, you've been put on a waiting list. And we're hoping to do that in a way that we use all the resources we've got in an efficient way to keep the waiting times and the waiting lists as low as possible.
Chair, if I may, so Greg's covered that very well indeed. And first of all, I'd just like to say thank you to Chair and the committee for your kind words, which I will pass back to the Trust. As Greg's alluded to, the aim of the reset group is to have all pathways back to receive referrals. A number of those have gone by new pathways, and that's where there's that collaborative working, where a consultant is seeing that referral immediately and ensuring that the right process is put in place. So it's trying, as I said earlier, trying to make our pathway, the journey for the patient, to be as efficient and as effective as possible. Literally before I came onto this meeting, I was at the executive meeting, and another 14 pathways have been declared fully open for referral. And as Greg has alluded to, it's the intention that early into September we will have nearly all pathways back to receiving full referrals. But as I said, trying to switch as many as we can to the new pathway of working so that there is early consultant involvement and not just an acknowledgement that the referral's been received, but a decision making early on to ensure that patient's journey is as efficient as effective as possible with the constraints I've described earlier.
Thank you both. I'll just continue on this theme before I bring another councillor colleague in, if I may. I know with the pathways being reopened and clinics and referrals, etc., that there is tabloid concern about the issue of not the first referral from your GP to pick up on those that have been waiting, but then the second, if needed, referral back to wherever the patient has to go. And that seems to be a concern nationally. I don't know locally how that's going on in terms of the onward progress on that pathway. And to follow that through as well, could I ask Andrew if you have the information, and if not, maybe you can follow it through with our officer, Andy Wood, for the committee. What's the staffing situation in terms of consultants? Can you hear me?
Sorry, Councillor, you broke up.
Did I
can hear you. I don't. Yeah, it's probably my end because the broadband where I live is not the best in the world.
That's okay. That's okay. Concern about second onward referrals seems to be an issue, and on top of that, I asked the question: what is the situation with the consultants to deal with the issues that the patient may need?
Yeah, well, thank you for the question, Chair. As I said, we are at 72% of our pre-COVID levels for first-to-patient appointments and follow appointments at 92%. We are ensuring that all referrals have been reviewed and that every referral had to be, even during COVID, reviewed every 12 weeks to make sure that we are picking up the issues as required. And obviously some of those patients came from being non-urgent to urgent, and we did maintain those throughout. I am, as I said before, pleased to report that we were able to maintain our cancer pathway. It did drop in early March down to 40%, but by setting up Pontefract as our cancer site and as a green site, which has implications for the new IPC guidance around the PP requirements, we are trying to run that site as efficient as we can, so that there is consultant review of all referrals, and patients that were previously referred, there will be consultant review of all those referrals as well, to ensure that patients who may have been worried about attending the hospital can be reassured that now we're in a position where we have definite green sites both at Pontefract and at Dewsbury. Pinnerfields will always be a mixed site, but with the new guidance that's been issued around how we change our IPC, which is infection prevention and control measures, we hope to try and dedicate particular green wards for the surgery at Pinnerfield. And the same with our outpatients, in that we are trying to ensure that patients that do require to be seen can be seen as efficiently and effective as possible, but obviously we are trying to triage that process to make sure we see the patients that needs are greater than others. And the best way to do that is that we are using our consultants along with our GP colleagues who've been really, really helpful. I must reiterate that, in ensuring that we are prioritising our patients appropriately and seeing them as quickly as possible. The exact numbers of where we are, I can find and report back. That's not a problem at all. But all I can reassure the committee is that we are moving at pace. We are ahead of our predicted targets that we have to issue. We had to issue further statement today, and we are ahead of our previous aimed targets, and we continue to work at pace to ensure we are back to, as soon as we can, 100% of our previous activity the same time last year.
Thank you, Andrew. Just to follow up on the last question again, my last conversation with the Chief Executive of the Trust was he was looking at a requirement for all consultants in their specialities to draw up a spreadsheet in order to deal with the situation they were in. I do know that urology was a particular problem, and ophthalmology was another. If you haven't the information today, I understand, but I think the committee would like to know the situation in terms of the consultants, any vacancies, and how you're actually needing to cover those, if that is the case. I'll leave that one with you, Andrew, so you can bring that information back through the scrutiny office, Andrew Wood. I want to come back to Greg, if I may, before I bring Councillor Rowley in. I was very pleased to hear that the rules have changed, Greg, about the definition of age, if we're being ageist in these things, and I understand why, of who is eligible for the flu virus. You've said that the situation has changed now in terms of the age of people who can get it. When did that change happen, Greg? And if I really appreciate, when did the change happen and how were GPs notified?
I'm going to guess, Chair, that it was about 3 or 4 weeks ago. There is an annual flu letter that comes out to all practices, which gives the information, and that comes in stages, saying what the vaccines are, what the risk groups are, and getting people ready for ordering the vaccines. And then we had a supplementary flu letter, which was announcing that in the light of the COVID situation, that the over 50s would be included as well, and that further vaccine supplies were being sourced nationally in order to meet that demand. So I would say roughly about 3 to 4 weeks ago.
Thank you, Greg. Could I suggest that you actually revisit those letters to make sure that the practices have got them and they're actually applying the new age rule? Because of yesterday, a circumstance arose where a pharmacist across the road from a GP practice was offering out the flu vaccine to medical and over 65s. A person I know contacted the doctor's practice across the car park, and they were told yesterday that the situation was it was only the over 65s. So the communications along the line somewhere have got lost, mixed, or the messages are not being relayed to the reception staff, and that is actually very worrying, because people now will be under the assumption that that rule is still applying in terms of medical and over 65 at a chemist, NHS, or you can buy them for £12.50, and then the doctors are giving out a different message to what you've given us today. So could I please, when this meeting finishes, reiterate that the doctors' practices are reminded of the new change so that the people who are eligible can actually get the flu vaccine at the appropriate time. I'll leave that one with you, Greg, because that's disappointing in terms of the information that I got yesterday and you've given today.
Could I just reply briefly, Chair, if I may, to that?
Yes.
Because there is a reason for that. When the flu vaccine orders are placed, this was before the pandemic, there are 2 kinds of vaccine, if we exclude the children's one. There's an over 65s vaccine and there's an under 65s vaccine. The orders are placed, the flu vaccine is manufactured and deliveries will start. The under 65s vaccine will be used first for patients with other conditions like diabetes and respiratory disease as well, and then it will require additional volumes of vaccine to arrive to do the healthy over 50s and under 65s. So the message at the moment is, yes, the over 50s will be included, but we're doing the people with other health problems first. Otherwise, we'll run out of vaccine before the additional vaccine arrives, and we'll end up vaccinating people who aren't at the highest risk if we're not careful. So the messaging does need to be careful and right.
I appreciate what you're saying, Greg, but that's not the case, because the person who was told at the doctor's has an underlying medical condition that's down on their record, who's actually had the flu vaccine for years, and yet the reception staff at that hospital practice were not given that information. And I think I understand about the flu vaccine. Yeah. I understand about the nature of getting enough but it's the message again. It's the mixed wrong message again. When somebody contacts their doctor about the flu vaccine, and they give the reason is that they are on a medical list, it's very easy for the receptionist or somebody else to actually just check. That isn't happening. So the over 50 on a medical list was not told that yesterday. So I think we need to get in touch very, very quickly and iron that message out so as it comes across that it's medical need over 50 that is available.
Absolutely, Chair, you're absolutely right about that. People with an underlying health condition of any age are eligible, and if you could send me the detail of which practice it was, I will take it up directly with them, and I'll make sure we communicate out to all our practices to make that clear.
Greg, the message here is it needs to be communicated to all practices to make sure that they've got the right message, because otherwise we will have vulnerable people with an underlying medical condition believing that it could be November or December, dependent on the amount of vaccine that's available, and that's understandable. Medical condition that they can't have it. So I'll leave that to you, but I will have a contact later on with your good self to make sure you've been in touch with all practices and to make sure that it's plain what the understanding is. So thank you for that, Greg. I'll leave it with you. Councillor Rowley, Olivia, you can ask your question, please. Thanks for waiting, Olivia.
Thanks very much. Very complex situation, isn't it? I can't get my head around the whole idea that, in fact, you're actually starting to operate at a much higher rate. What has happened to the people that were hoping to have treatment back in February or March? And will they be informed that some of them may never reach the top of the list? Because if you're dealing with the current cases, what happens to the previous ones when presumably as you increase activity, more people will keep coming onto the list? Are there enough beds? And I just worry that in fact people think that they're on a list and yet may never be treated. And then finally, if there is another mass virus attack on us, have you enough PPE? Thank you.
Councillor, if you're happy, I'm happy to respond to that question.
Yes, please do, Andrew.
Yes. All lists have been reviewed. So if somebody was on the list, they all been reviewed, and obviously we are prioritising. But the important thing is that all patients on that list have been reviewed and will continue to be reviewed with consultant involvement. So we are cognizant that obviously that there is a long list. I'm pleased to say on the cancer list that we have been, with the setting of the Pontefract site, able to work at pace. And we have had agreement from National NHS, NHS ENI, that they are prepared to pay for extra sessions so that we continue to try and catch up where possible. One area in particular was endoscopy, and we have outsourced 3 extra clinics for endoscopy to try and get us back to where we were. Same with ophthalmology, as alluded to before, there was a build-up, but again, we've been able to outsource and use, including the independent sector, where we have been running quite a number of our trauma and orthopaedic lists. So this is where we've been able to increase our number of operating capacity to ensure that we are, on the operating side, able to see these patients and provide the care that they've been waiting for. But our outpatient activity with the new pathways as described, but also with some of the previous pathways, and by using a mixture of non-face-to-face and face-to-face appointments, they are working through the list. So anybody that has been referred will be given the opportunity to attempt for. Some people that were on the list have actually now declined their appointments and said they no longer require them. Some people were moved onto the more urgent list. But I can assure that the Trust is working through all those lists, all those patients that have been referred, to ensure that we do get to them. The second part of the question was around PPE. The PPE has been a challenge, and I now chair that group. What I'm able to report, very pleasingly, there's a Trust. We did go outside of the national guidance and we did procure some of our own PPE to make sure we had the resilience. National guidance, we would have unfortunately failed in that provision. So to ensure that our staff are safe and therefore our patients are safe, we did go and procure, and I'm pleased to say that the government has now reciprocated and agreed to cover that cost. In the the whole area, known as the ICS, there is now enough resilience to ensure that we have PPE for the next at least a month, and we're increasing that to 6 weeks. So we meet every week at Pindar Fields. We have 2 meetings, one to ensure that we have enough PPE to sign off all the increased activity that's taking place with all the clinics coming on and the operating, etc., and investigations, but also to ensure that we have enough of buffer of PPE that we can manage and a further increase in activity with the increased prevalence that's been reported earlier. So we're working extremely hard to make sure we've got resilience. And into that, if, for example, we have procured and we are using reusable materials like gowns that can be washed, been tested and approved by the Health and Safety Executive and the NHS E and I, so that we have got that resilience, and we've been able to procure gowns for people to wear when they need level 3 protection for aerosol generating procedures, but for operating. That we have tried to build in as much resilience as possible, and that's all the main aspects in my role as the clinical lead for EPRR.
Thank you.
Can I just ask, are there enough beds? Because if we're using the private sector, that's one thing, but I mean, basically we've got wards devoted to COVID. So even if we were able to ensure that people were able to move up straightforwardly, would there be enough accommodation for them?
And that is that's a very good question, and that is the challenge, because obviously our estate is what our estate is. And yes, could we do with more beds? Yes, we could, but with more beds, we'd need more staff. And I'm pleased to report that we do have an increasing of nursing numbers, and that continues as a program which will comes online very soon, where we'll have 150 extra nurses. Some of those nurses coming from abroad under safe measures, but we are increasing our nursing numbers because that has been one of our challenge, and we remain at the moment with staff that are still off shielding, or they are off as contacts, or some unfortunately positives due to this COVID outbreak. Though the challenge is not just the number of beds, it's also having enough personnel to manage those patients. And therefore we have used the independent sector, as the government has increased that contract with the independent sector, and we continue to outsource where we need to, so that we can try and get back to where we were pre-COVID, or the same point as this time last year. But yes, I think all hospitals could do with more beds. It is a challenge. What we have to make sure is that we use our estate efficiently. And one of the targets you will have seen in the presentation that we shared with you is making sure that our medically optimised and fit for discharge patients are kept below 30, because that's obviously freeing up beds by making sure that we do have that through of patients and that they are discharged safely back into the community. So we are working with our CCG authority colleagues to ensure that process is in place to make us as efficient as we can.
Thank you, Andrew. This might seem a silly question. I'm always interested in learning how things are being done, as you'll appreciate. You said about gowns that can now be washed. Who's doing the washing of the gowns?
So we have contracts with a company called Synergy, which provide that washing facility. So the gowns have to be washed at a certain temperature. As my public health colleague said earlier, as long as things are washed at the right temperature and everything, they can be reused. So we have a stock of single use, which we use majority of, but we have introduced gowns into what we call our red areas, our areas that are undertaking aerosol generating procedures, to make sure that we continue to have the resilience if there is a sudden peak of single use. So we are using reusable where possible, and that even extends to some of the masks that we're using. We were able to procure some reusable FFP3 masks, and actually that's quite good news for the wearer, because it's their mask and they keep their mask, and people are very happy with that. So we are going to put in as much resilience as possible, very cognizant that of the increased prevalence and the challenges of the second wave that will probably come with winter, because with winter it will not just be COVID, it'll also be respiratory syncytial virus, it'll also be Norwalk, etc., and flu. So we have to put as much resilience as we can.
Well, it's good news that you've been able to procure the masks, etc., bearing in mind that some contracts were given out by the government and then they had to withdraw them because the masks that had been provided weren't meeting the spec that's needed within the healthcare system. That's really good. And last question, Andrew, if I may, you've mentioned the upcoming winter pressures. If you don't know, I'll appreciate it. and you can get the answer late. We'll be having a meeting, I'm sure, with Martin Barclay pretty soon. It's this time of year as well when the Mid Yorkshire normally procures anything up to 50 extra beds out in the community in normal times. Well, we're at normal times now in terms of the issues that you referred to, catering for COVID and catering for the flu situation over a winter period. Are you aware of the procurement that's taking place about extra beds for capacity for the winter flu as we normally had it? And if not, I can appreciate that you can forward that information on to our scrutiny officer at a later date.
Thank you, Chair. So the winter planning has started. It started over a month ago, and we are looking at the procuring the beds. I can't give the exact number, so I will report back that information for you. But all the winter planning processes started well over a month ago to ensure that we have got the resilience in place. And Michelle Eardley, who's the head of our urgent care, non-planned care sector, is working through the winter plan. And I show tomorrow I'm at another meeting about winter planning to ensure we have got the resilience. I can't give the exact number of the beds that have been procured, but I know the process is in place.
That's very useful, Andrew. Thank you very much for that. Okay, I think we've gone through the papers and asked for some further details to come back to us, which is going to be useful. I've no doubt that as the months go ahead, we'll, as a committee, be looking at these issues again and keeping the members, as well as the public, aware of the situation within the Trust and the clinical commissioning. To hear from Ruth Unwin Communications saying in relation to concerns about the practices that I mentioned to Greg about the age issue and information to practices about this matter. If members will now agree, we can look at the of the presentation we've had today. We've received the report, and obviously we've had assurances here about the pathways for the future. There's still some questions that need to be answered for the winter planning, and indeed the if forbid we do have a second phase of the COVID, and we've heard about actions from the Trust and the CCG to mitigate against any future surge in the pandemic. I would suggest to members that at this stage we note the information from today, we await the further information that we've asked from, and then I'm sure, as you know, we'll be coming onto the work programme for the future, and these will be topics that will be on our agenda. So if you can agree that that's the process, if anybody disagrees, can you let me know, please? All in agreement, then thank you very much. And at this point, can I thank Dr. Greg Connor and Andrew Smith for being with us today. Sorry that you couldn't get in, Ruth, but you managed to get a phone call. But thank you for being with us, and thank you for the brief update that you sent as well. With that, I'll close that agenda item, and we will move on to the next agenda, which is the Chair's briefing. And this is on, it's your agenda item 8, and it's pages 49 to 56. And this is just to provide you all with a summary of the Chair's actions and discussions between the formal meetings. It's information that we always give out, and I'm sure that it'll be useful to you to know that actions are still taking place in COVID and has been outside of our committee structure. So can I just ask you to note the report that you've been given today, and hopefully the next report is for the next committee, where we'll be able to even update on the further situation in terms of our residents of the district. Do you agree to take that note, that briefing note? Nobody against, so can I take that's all agreed? Thank you. That takes us on to item 9 on our agenda today. And as you're aware, because of the COVID outbreak, the normal passage of the committee's annual report did not follow its normal pattern. It had normally been presented to the Scrutiny Management Board as part of the overview and scrutiny annual report, and it would be passed to the Council for consideration. In the absence of that process, the report was agreed by chairs and is presented today for members' information. As you look through the report, obviously there are a lot of issues there, and again, some of these are recurring. They will be looked at in light of the program for the future, but I would suggest to members that because of the situation that we're in, we'll have to be, I think, more cognizant of the reports that go on the agenda for the future. We will, of course, have to be flexible for the forthcoming year in terms of how we deal with any situations of an emergency nature that could arise. And the recommendation on this is that you note the Appendix 1 of the report, and it's been included in the annual overview scrutiny report. Members agreed to do that? Nobody against? I'll take that. That's agreement. Thank you. Item 10 on the agenda today is the work programme, pages 67 to 69. And there again, this is anticipating, as I've already mentioned, the business of the committee up to and including December 20. It may be subject to change given the nature of the situation, but also members may have to consider additional meetings to deal with ongoing issues. The Pontefract Birth Centre, for one, and obviously any other emerging issues that may need the committee's attention. The 3 months that's been identified obviously are very specific issues, but as I say, if anything does arise, we'll have to deal with it as a matter of urgency. And with that, looking at that report, the recommendation then as that's our work programme up to December 20, and I'm asking that the recommendation is that members consider and note the report and obviously the flexibility that we will need for the programme for the future. Can I take members' views on that? Are you agreed? Nobody's indicated against, so that is the way we'll work for the next calendar months in terms of our workload for the committee. Thank you very much, members. On the forward plan of key decisions, that's pages 70 to 87. It's obviously to inform members of this committee on the forward plan which of those terms of reference is applicable to our committee. And one decision has been identified, and that is the procurement of sexual health services for the Wakefield district. So will have to take some place within our programme as appropriate in terms of the other issues that may have a more emergent nature. That then, if you can agree the forward plan and accept it as a plan for the future, that concludes our agenda for today. Andy, can you hear me? I think Andy seems to have gone again.
Yeah, I'm here, Chair. Sorry about that.
Okay, Andy, right. We've been through the agenda for today, and obviously the next meeting of the Scrutiny Committee for Adult Health is on the 22nd of October at 2 p.m. If, Andy, this is a question for you, if the questions of more information is obtained from Greg and from Andrew from today, it will be possible, or I'll rephrase that, will it be possible that we include that as further information in terms of, we've identified the topics now up to December, but this may be part of the future engagement role with the Yorkshire and with the Clinical Commissioning Group. Is that how we can keep it hot on the agenda, Andy?
Yes, Chair, obviously you've summarised the work programme. It's obviously COVID-19 related in terms of its aftermath and potential re-emergence, but obviously there are other issues that are quite prominent also, not least the Pontefract birth unit, for example, which will come to some kind of conclusion possibly in the autumn, and the committee will obviously have to consider that at that stage. So, having said that, there will be probably potential for further meetings, but as you've indicated, we do need to be flexible. In terms of the other information that you've requested, I'll ensure that that's procured and circulated to members, but obviously we reported back to committee formally through the meeting process. Just to say again that we may have to have additional meetings to deal with some of the issues that will arise.
Okay, thank you for that, Andy. With that, then, that closes our agenda for today. Next meeting Thursday, the 22nd of October at 2 p.m. Thank you all for your attendance today, and safe health to all of you. Keep well.
Thank you, Chair.
Thank you. Bye.
Thank you, Betty. Bye for now.
Bye.
Thank you, Betty. Bye.
Bye.
Thanks, Betty. Bye. Bye, everybody.
Bye, everybody.
Thank you, Betty.
You're welcome.
Thank you, Betty.
Good to hear all